Mr. Chairman, ladies and gentlemen, I'm not a laser man, but besides my family, blood is my love. And then I want to thank very heartfully Professor Oshiro and all the people having invited me, not only for the honor of the invitation, but also because I came here in a way as a foreigner, and now I really feel a friend of the people I've met. I just go through in order to give you in 10 minutes the possibly full idea of what is the European School of Transfusion Medicine, which is also named colloquially Estm. And to do that, I will go very quickly through a series of pictures and of slides, many of which don't require any comment because they are short and self-expressive. And if possible, I will try to spare 1 or 2 minutes at the end to make some final considerations. Now, the first thing is that the STM was not born by chance or by accident, but was a sort of ripened fruit of the times in Europe, which were somehow announced much earlier by two or three important institutions like the Council of Europe, which was already there and developed many studies about the need of teaching, of proper teaching of transfusion medicine in Europe, by the ISPT in its regional section, and the Italian Society, which was collecting the appeal made by the ISPT previously to start having some international European relationship in the immediate future. Now, one of the very important preparations was the running of some, was the running of a series of, I'm too quick, a series of meetings, symposia for European cooperation were called, which were organized either by the Italian Society in Italy or by ISPT European region around Europe. These are the contributions which were already appeared once we decided that maybe it was a case to start thinking of the colleagues and immigrants coming from Eastern Europe. And this was one of the reasons we decided it was our turn to do something in order to harmonize the whole practice of transfusion medicine in Europe. Now, an appeal was coming from this meeting of the International Society of Blood Transfusion, European region, where they recommended to all the national societies of Europe to start doing what they could. This was already in 1989. The situation was, and it is still now, very different in Europe. At the medical undergraduate level, there is substantial basic information on transfusion medicine which is not really considered in university medical curricula, except in a few countries, and the tremendous need of a European proposal of common curriculum. And this was what we started doing in a meeting where everything was discussed and that full picture of the situation in all countries of Europe was shown. There was a nice informal meeting in a way in Israel where we were invited to analyze the situation with the Israeli and the American one, and we tried to start thinking about. At medical postgraduate level, of course, the own specialty of transfusion medicine is only present in 3 or 4 states, and what is even more lacking is a presence of an adequate, let's say, part of the curriculum in all surgical and medical specialties concerning transfusion medicine. And the need of a European proposal is clear. Our aim in Europe was to tend to have it as a separate specialty, at least in countries where it was necessary. And this was discussed already in 1991 in an ISPT meeting in Prague. And it was proposed, this is already outdated, of course, because time has passed, but it is basically still a complicated network of teaching and education in the blood and immunological specialties. In other words, the definition which came out from this meeting was that specialist in transfusion medicine is a very complex figure which must have a clinical and laboratory expertise, hematology and immunology and blood transfusion practice, and care about many things: planning, organization, quality assurance, any diagnostic and therapeutic problem of patients, and be also able to teach transfusion medicine further and help research and development in the field. In a way, it was conceived as a bridge linking the donor to the patient in all the aspects of this pathway. The reasons for creating an educational institution, which is a free association, a voluntary association, was that we've realized that beyond academic schemes, professionals and clinicians should have been addressed continuously in a sort of continuing medical specific education. And in a way that specialists of transfusion medicine, given the difficulty to reach a good understanding in the hospital with very, very clever but very ignorant in the specific field clinical colleagues, they should have acted as a sort of educational catalytic enzymes, as we wanted to call them, to foster some more communication. And the basic thing which proved to be the real motor of this initiative was the two obvious considerations that in Europe at least there was two apparently contradicting phenomena. One was the under-transfusion due to justified fear of unsafe blood, since of course HIV and other diseases were known. And on contrary to this, and paradoxically, and very relevant, uncritical mistransfusion due most of all to incorrect clinical criteria where blood was used much more often than necessary. The widespread ignorance of basic principles of clinical transfusion practice was again something to be fought and to be overcome. And the minimal knowledge of transfusion medicine in most European universities was another reason to start doing something. That's why the Estm started. And the main topics in exactly 80 courses done in these 17 years have been grouped here in a sort of subjects which were dealt with more or less in different courses. And just to give you an idea of the width of this activity, because in fact transfusion medicine is a very wide specialty where we must learn many things about many clinical and laboratory aspects of medicine. And in the last few years, however, most of our attention has been given to the clinical medicine and the contribution of clinical medicine to blood safety. Just to give you an idea, we made courses by now in 28 European countries, listed down there, in order of frequency of courses, and in 3 countries outside Europe: Brazil, Argentina, and Israel. Half of these courses are being roughly divided into clinical transfusion and non-clinical transfusion. As you see, it has been very considerably dealt with. These 40 courses have been grouped just for the occasion in a sort of subchapters of clinical transfusion general practice, 7, transfusion medicine in emergencies and clinical specialties, 10, transfusion safety and hemovigilance, 12, quality management of transfusion medicine, 6, blood sparing, 5. This division, of course, is a bit conventional. In many courses we dealt with more subjects. These are just a quick list of the subdivision I did before, just to give you an idea. The prevailing mental attitude we discovered in medical science is to leave to others the responsibilities of application in medical practice. And more generally, we learned that transfusing medical science into medical practice is a real problem today, at least in blood transfusion. The basic requirements for an acceptable safety have been somehow laid down, and they are very complex, of course. Does it mean that I have only 2 minutes, or that I overcame already this? I have no idea. I see something lightening. Okay, I try to be quick. These concepts have been widely accepted in many countries, and I must underline that in Europe, which looks so uniform from abroad, there are very different situations, also concerning transfusion. And there is a risk of an increasingly diverging quality of transfusion medicine if the education, political awareness, and human education would fail. The basis quickly before the top of the pyramid is a very clear concept what Europe concerns, to avoid that this difference becomes greater. And we also fully agree with the WHO sort of suggestion saying that much more than any other financial or political help, the human dedication consisting in political maturity, moral solidarity, cultural development, and medical competence are really basic ingredients for progress in transfusion. Of course, the WHO also told us that responsible voluntary donors, essential blood testing, and rational clinical use of blood components are the need, the essence for making a blood safe in the transfusion. And this is a result of a continuous education to quality. This has been widely accepted. What quality and hemovigilance is a relation? Because very often many countries are waiting to have a statal system of hemovigilance to start producing quality. And this is, of course, we fought against this. And quality could not be waiting until hemovigilance is there. Hemovigilance must be based on quality after quality has been exerted and practiced. And this is slowly gaining popularity, this concept, but it's not very easy. It should be based on quality and not creating or preceding it. The quality of clinical indication for transfusion therapy is another important issue which has been favored again by the WHO. We tried to establish a concept of clinical quality control, which is a very hard one, of course. The hospital transfusion committees have been created nearly all over. Clinicians started understanding that they should become co-responsible with the safety of blood of their patient, because the patient under their responsibility. And we somehow wanted to summarize this autolated picked sentence for the category of transfusion people by saying that blood is too important in our life to be left only to others, which means to transfusion people. Everybody should be involved. Competent and effective professional interaction between transfusion medicine and clinical specialists is the aim of this, which has been reached only partly, but in some countries very